Yeah, please start.
Good evening, everyone. My presentation is on Chota packet Badha Dhamaka, that is a microspherophakia. So before we begin in with case presentations, let's briefly brush up the anatomy. The lens is such a human organ that starts growing in the gestation but continues to grow throughout the life. So it starts less than 3 months, wherein it is vertically elliptical, and around 3 to 8 months there is this spherical growth. So it is at this stage that if it gets arrested, it won't grow further and it will remain spherical throughout the life. So there is this arrest of tunica vasculosa lentis that will persist as a spherical shape throughout life, causing this microspherophakia, and this has been backed up by the MRI imaging in the gestation. So what actually causes equatorial growth of the lens is the zonular strength on the equatorial margins that pulls the lens in the equatorial direction, which causes their increase in the anterior-posterior diameter and decrease in the equatorial diameter. So beginning with the case details, 24-year-old male presented with a routine examination, and on refraction, we saw the patient had -9 myopia. So what do we expect in a myopia case? A deep anterior chamber and probably increase in the axial length. On the contrary, to our surprise, the patient had a very shallow anterior chamber. And also axial length was pretty normal. But the lens thickness was increased. So there was this lenticular myopia. So when we suspected microspherophakia and we confirmed it on AIOS, we safely dilated the patient in the supine position and did the fundus examination in the supine position. So in full mydriasis, we can see the 360-degree equatorial margin. And this is the AIOS picture. So the hallmark triad of lenticular myopia, shallow AC, and angle closure glaucoma can be present. Prophylactic peripheral iridotomy was done, and the patient was called up for 6-month follow-up. The patient was doing quite good, but there was another case, the patient with PI and on Dorzox T, still when the patient presented on follow-up, he presented with again a shallow AC and a patent PI. So despite prophylactic PI and on AGM, the pressures were not controlled. They were as high as 42 and 40. The culprit here, in this case, is not glaucoma itself, but it is a secondary cause due to the microspherophakia. So in such a case, it is safe to do a clear lens extraction because that is the cause of high IOP instead of putting the patient on, again, AGMs. So on 1 month post-op follow-up, the iris claw lens was placed and the PI was done, and we can see the AC is well formed and pressures are maintained. So lensectomy is effective in controlling IOP without any AGMs in 69% of the eyes, and the other 7.7%, there are some other preoperative risk factors for glaucoma. The take-home message is that observational PI can be done for initially, in wherein the IOP is normal and angles are open, but lensectomy may be required if the IOP is high despite a patent PI or there is phacodonosis or subluxated, since the main seat of pathology is in the zonular weakness. Then the question comes about the indications of IOL surgery and IOL choices. So it can be a scleral fixated IOL.
Yeah, thank you.
One question, why didn't you put atropine in this patient? Atropine is considered to reduce the pupillary block.
Yes, sir, but to prevent pupillary block like prophylactic peripheral.
There is only one condition in glaucoma where atropine helps, that is
Inverse.
yeah. This is what we call as an inverse glaucoma. So atropine, if you should try atropinizing the patient, and many a times with that glaucoma disappears. Second thing is that lensectomy is the treatment of choice if you don't get the relief from atropine.
Thank you very much. Can I have